Thank you to the organizers for inviting me, allowing me to speak. My name is John Markley. I practice mostly at San Francisco General Hospital. And next. No financial disclosures. And I will be talking about off-label use of some medications. So as Dr. Butwick has graciously summarized for me, here in this study, pregnancy is a hyperfibrinogenemic state. Here you can see the non-pregnant patients having fibrinogen levels, serum fibrinogen levels that you're used to seeing in the 250 to 350 range. But as pregnancy progresses through the 3 trimesters, there is a steady increase in fibrinogen, serum fibrinogen concentration, such that at term, you get about a 50% increase in serum fibrinogen concentration. So this is the hyperfibrinogenemia of pregnancy. What you see in at least severe postpartum hemorrhage is what's known as a dysfibrinogenemia. This is a slide that Dr. Butwick showed a couple of talks earlier, but this was a prospective observational trial where they compared non-severe postpartum hemorrhage to severe postpartum hemorrhage. And they identified many coagulation factors that were different between the 2 groups, but the only one that was independent parameter associated with severe postpartum hemorrhage was a low fibrinogen level, and this is through the multivariate logistic regression modeling. Here you can see that in the non-severe postpartum hemorrhage, average fibrinogen level here is around 450. In the severe group, it's around 350 milligrams per deciliter. Further analysis by this group showed that if your fibrinogen level is above 400 milligrams per deciliter, there's about a 79% negative predictive value for postpartum hemorrhage, and that no one in the non-severe postpartum hemorrhage group had a fibrinogen level of less than 210, meaning that if your fibrinogen level is less than 210, it's 100% specific for severe postpartum hemorrhage, not just postpartum hemorrhage, but severe postpartum hemorrhage. I'll show you 2 more studies of the importance of fibrinogen in postpartum hemorrhage. The second one here is a retrospective study where these authors concluded that once you're down in the 200 milligrams per deciliter range, it's almost 99% specific for severe postpartum hemorrhage, meaning that there's very few false positives, which means that if you're below 200 milligrams per deciliter in a postpartum hemorrhage, it's almost certainly severe. Now with this high specificity, of course, it comes with a low sensitivity, meaning that the vast majority of patients who have severe postpartum hemorrhage have fibrinogen levels over 200. And in the last study I'll show you about the importance of fibrinogen in pregnancy is a prospective study here where they took postpartum hemorrhage patients, drew their fibrinogen levels before administration of any blood products, and then went on to identify what products and how much they received. What you can see is that a lower fibrinogen level here of around 240 is associated with greater than equal to 4 units of PRBCs transfused compared to fibrinogen level of 390. This carries over to total blood products transfused, PRBCs, FFP, and platelets. EBL is also correlated with the low fibrinogen level and need for invasive procedure. So hopefully I've been able to show you that pregnancy is associated with a higher fibrinogen level, and that postpartum hemorrhage, at least severe postpartum hemorrhage, is associated with a low fibrinogen level. But does this necessarily mean that we should be replacing fibrinogen during these postpartum hemorrhages? The importance of fibrinogen and the low fibrinogen state has made its way into postpartum hemorrhage algorithms, again shown by Dr. Butwick's group. Here in 2012, previous here, let's go back. Here in 2012, his group showed that if fibrinogen level is less than 100, time to give cryoprecipitate. But then just 3 years later, here in 2015, the fibrinogen level, if fibrinogen level is less than 250 now, give cryoprecipitate and or replace fibrinogen with fibrinogen concentrate. So just over 3 years, you see an evolution of postpartum hemorrhage algorithms. At least one institution has taken upon themselves to make a distinct massive transfusion protocol for OB only. So this is an OB-specific MTP, and this emphasizes the importance of fibrinogen. Here at this institution, if you activate MTP on L&D, you get PRBCs, you get FFP, but you also get some cryoprecipitate automatically in your MTP. So what are our options for replacing fibrinogen? There are a few. The liquid, never frozen plasma. The only place in the Bay Area that I know uses that is Children's Hospital Oakland, and I'm pretty sure not too many women are delivering over there. There's FFP. There's thawed plasma, which is basically FFP that's been laying around before expiration. There's a few pathogen-treated plasmas out there, and then there's cryoprecipitate and fibrinogen concentrate. I will spend the rest of the talk talking only about the FFP, cryoprecipitate, and fibrinogen concentrate. Just briefly, the way they make fibrinogen concentrate, it does come from humans. They take cryoprecipitate, they go through a process of adsorption and precipitation, followed by an important pasteurization step that's thought to inactivate the pathogens. It gets reprecipitated, dialyzed, filtered, and then lyophilized. More about fibrinogen concentrate, another disclaimer I'll give you is that the FDA has only approved the use of fibrinogen concentrate for congenital afibrinogenemia or hypofibrinogenemia states, prevalence of which is about 1 in a million. The FDA specifically says this is not approved for acquired bleeding disorders, and both of the products that are available in the United States, RiaSTAP and Fibrina, clearly state in their package insert that this is not indicated for dysfibrinogenemia. That said, I will spend the rest of the talk talking about using it for acquired bleeding disorders of postpartum hemorrhage. So these are the two fibrinogens that are available in the United States. RiaSTAP is the one that's out and it's marketed. Fibrina or Fibrija, it's approved but is going through the marketing part, so I'd be surprised if anyone here has used it. If anyone's used it, it's probably just RiaSTAP. These products end up being pretty similar. Both are pooled human-derived. You get about 1 gram. There's a range. It's not exactly 1 gram, but you get about 1 gram of fibrinogen concentrate. It comes lyophilized. You can store it at room temperature or in the fridge, so you can just put this in your anesthesia cart. You reconstitute it in 50 milliliters of sterile water, not normal saline, not LR. It's got to be water. This is not included with either product. And you administer it over 10 minutes IV, as either pushes every once in a while or put it on an infusion pump. There have been, in the cardiac literature, people are pushing this drug, by the way. Differences are slight from what I can tell. I've never used Fibrina, but from the sound of it, it's pretty similar. RiaSTAP, it says you can if you reconstitute it, you have to use it within 24 hours. And with Fibrina, you have to use it within 4 hours, okay? Fibrina also comes with this, transfer adapter for your water in order to reconstitute it. It also comes here with a filter. There are unknown cost differences at this time between the two. One slide here on reconstitution of RiaSTAP. If anybody's used it before here, you know that it's kind of a pain to reconstitute. The package insert says to gently swirl it. Do not shake it. If you shake it, it just foams up, and now you're not giving anybody any fibrinogen. Somebody actually studied what happens if you shake the fibrinogen. They took protocol reconstituted fibrinogen, RiaSTAP fibrinogen concentrate here, and then they shook it up here, and they tested whether in these reconstituted product. If you actually damaged the fibrinogen and you did not, there's no difference when they sent this rapidly reconstituted fibrinogen off to the lab, no difference in concentration, and there was no difference in function by thromboelastography. When I reconstitute this, I do a kind of in-between swirl and a shake. You get a little bit of foam, but what you end up doing is you give all of this over 10 minutes, and by the time you've given it over 10 minutes, a lot of this foam here has settled down, and then you give it. So it's not really an issue. By the way, this is a N=3 study. They really just took 3 bottles here and 3 bottles here. So I don't know what you can conclude. So how do you dose fibrinogen concentrate? I'll show you 2 different ways. The first one here is based on serum concentration level. You get you can calculate the dose in milligrams per kilogram based on what you want your target fibrinogen level to be, and also what the patient actually has in the measured level, and divide by a constant. What you end up getting, what this ends up meaning is that 1 gram of fibrinogen concentrate raises your serum fibrinogen about 25 to 50 milligrams per deciliter. So you'll likely, if you're giving 1 gram, you're probably needing to give an additional gram or 2. Another way to dose fibrinogen concentrate is based on based on RoTem analysis, based on the FIB-10 maximal clot firmness. You can calculate the amount of fibrinogen concentrate to transfuse based on what you want your FIB-10 MCF to be, what your current FIB-10 MCF is, and your body weight multiplied by constant. What this means is that a half a gram of fibrinogen concentrate, so half of 1 vial, will raise your FIB-10 MCF by about 1 millimeter in a 70 kilogram patient. This is from the cardiac literature. So how does this fibrinogen concentrate compare in amount of fibrinogen you get to FFP and cryoprecipitate? As you know, FFP contains fibrinogen, however, it's pretty dilute. Here, I'm showing 250 milligrams per deciliter. That's actually quite generous. A lot of people say it's 200 milligrams per deciliter in FFP. So, but let's be generous. And so in a bag of FFP, you'll get, 750 milligrams. When you reconstitute fibrinogen concentrate and give the same volume of cryoprecipitate here, so this is 10 units of cryo and 2 vials of fibrinogen concentrate, each will be 100 milliliters, and you'll get about 2 grams of fibrinogen. What this means is that 2 grams of fibrinogen will be 2 vials of the RiaSTAP. It will have as much fibrinogen as 2 to 4 bags of FFP or 10 to 20 cryo units. So a little bit more about this fibrinogen concentration level in FFP, which again is generous here at 250 I'm showing you. Looks like this slide didn't go through all that well. There is a mathematical model that was published on transfusing 1-to-1 PRBC's FFP. This is a mathematical model, and what this is showing you sideways is that if you're just transfusing PRBCs and FFP, you'll never get above 200 milligrams per deciliter. In fact, their level here, they max out at 175 milligrams per deciliter here. And you need either cryo or fibrinogen concentrate to keep that fibrinogen level up in your patient above 200, which, as I showed you earlier, is those low fibrinogen levels are associated with severe postpartum hemorrhage. So in theory, you can't get there just with PRBCs and FFP. One slide on the cost of fibrinogen concentrate. You might be wondering, there's 2 studies I've identified, one in the UK where they compared what it costs to increase your fibrinogen level by 100 milligrams per deciliter, and what's shown here is that it's pretty similar costs, nothing drastic here. This one study in the United States compared what you can get in dosage of fibrinogen compared to a gram, which is cryoprecipitate, 5 units. And even when you factor in the blood banking costs and some wastage costs, fibrinogen concentrate in this study ended up more expensive, but it's not drastic. It's not 10 times more expensive. You are trading blood banking costs with pharmacy costs, so there might be some issues there. It's not like the Amicar versus TXA, which I don't know if anybody's here fought with pharmacy about that cost. It does not seem to be like a 10 times more expensive drug, the fibrinogen concentrate. I did ask at San Francisco General Hospital, our pharmacist, what is the cost to San Francisco General Hospital of fibrinogen concentrate? She couldn't really give me a real answer, and her initial response to me was actually it wasn't the fibrinogen concentrate that was so expensive, it was the water. And then she got back to me and gave me some that she had that backwards, but she still couldn't give me she couldn't give me what it costs, what fibrinogen concentrate costs, and it's gonna matter how in your different hospital systems how you negotiate your drug pricings. So adverse reactions to fibrinogen concentrate, at least in the obstetric population, really have not been identified. Here in a randomized study that I'll go into a little bit later in detail, they gave fibrinogen to 123 patients, and they found very similar levels of these sort of mild adverse events, and they, of note, found no thromboembolic complications from administration of fibrinogen concentrate. So this is the biggest study that analyzed adverse reactions in the obstetric population. There are smaller prospective trials that have looked at adverse reactions to fibrinogen concentrate in the obstetric population, and they concluded the same thing: no adverse reactions and no thrombotic complications associated with fibrinogen concentrate. Some of you might be wondering, how does fibrinogen concentrate compare to cryoprecipitate? I don't mean from this talk to say that fibrinogen concentrate can replace cryoprecipitate. Obviously, cryoprecipitate comes with a lot more than just fibrinogen. Fibrinogen concentrate, you're just getting fibrinogen. But there are some advantages of fibrinogen concentrate. No type and screen is needed. It's immediately available. It can be at room temperature in your anesthesia cart. Fibrinogen concentrate is pasteurized, so it's thought that the infectious transmission rate would be lower than cryoprecipitate. And likewise, there should be a lower risk of transfusion reaction with fibrinogen concentrate. There is a variance in the dosing of fibrinogen, but it's thought not to be as severe as the variable dosing of fibrinogen that you'd get with cryoprecipitate. Costs, fibrinogen concentrate may be more expensive depending on what you negotiate with through your hospital system. And of note, there's not been any association with thromboembolism in the obstetric population with fibrinogen concentrate, and there has been with cryoprecipitate. What I think would be a possible worthwhile study is treatment of postpartum hemorrhage with randomizing to FFP cryo, and PRBCs, of course. FFP cryo versus FFP fibrinogen concentration. You can imagine how hard it would be to recruit this study. So finally the data here, the data behind its use in postpartum hemorrhage in the obstetric population. This first study I'll show you, they studied preemptive treatment, so early treatment of postpartum hemorrhage with fibrinogen concentrate. This was a randomized double-blind placebo-controlled trial. They randomized women to get 2 grams of fibrinogen or placebo. Regarding their primary outcome, which was transfusion rate, they found no difference. However, this was thought to be sort of early in the postpartum hemorrhage course here. Median EBL was only 1,500, so non-severe. In fact, only 11 patients really met severe criteria of getting transfused greater than or equal to 4 units of PRBCs. The hemoglobin was not that bad in these patients, and the median fibrinogen level at the time of randomization was 450. So these were all normofibrinogenemic patients, or almost all normofibrinogenemic patients. No one in this study needed an invasive procedure, and in fact there was a delay in the administration of the blood product of the study drug. So what this study means is that if a woman is normofibrinogenemic and it's fairly early in the postpartum hemorrhage course, she's likely to get no benefit from getting the fibrinogen concentrate. two before-after studies I think are important to show. The first one, Dr. Butwick already went over. What I mean by before-after study, in both the studies I'll show you here, before they had kind of a standard of care and then immediately introduced fibrinogen concentrate into their postpartum hemorrhage algorithm. And then everything after that is the after arm. So this is the first of two before-after studies I'll show you. This one, they enrolled patients with sort of early postpartum hemorrhage of just around 1,500 milliliters of blood loss with evidence of a coagulopathy with a FIB-10 less than 12 millimeters. And what they found after introduction of fibrinogen concentrate into their postpartum hemorrhage algorithm is that they had a dramatic decrease in the amount of blood products that they used. Mostly this was due to reduced use of FFP and cryo, but a slight non-significant trend towards reduction in RBCs. Of note, they had after they introduced fibrinogen concentrate, their transfusion-associated circulatory overload rates dropped to 0 before they were about 10%. In another before-after study shown here, this one is actually very severe postpartum hemorrhage. They're already transfusing people here at greater than 18 units of PRBCs. And like the other the previous study, they randomized, the before arm just had PRBCs and FFP, and the after arm of the study had PRBCs, FFP, and fibrinogen concentrate worked into their postpartum hemorrhage algorithm. What they found is a dramatic reduction in the amount of FFP that they transfused, and like the other study showed, reduced their pulmonary edema rate from 57% to 24%. Obviously, this is a very small study. Okay, so the only randomized study for treatment of postpartum hemorrhage with fibrinogen concentrate came out recently. This was a multi-centered randomized double-blind placebo-controlled trial. Inclusion criteria of EBL of greater than a liter, ongoing bleeding, and at least slight evidence of a developing coagulopathy with a FIB-10 less than 15 millimeters. They dosed fibrinogen concentrate based on the patient's ideal body weight and what their FIB-10 result was. Their primary outcome was number of allogeneic units needed to be transfused after the patient got either the placebo or fibrinogen concentrate. A little difficult to recruit. This was I think this is over 4.5 years. They only got 55 patients enrolled and analyzed here, so not a large study at all. And what they found was no difference. No difference in their primary outcome, median of a unit treated in each group. What they did find, though, on subgroup analysis, that patients with the evidence of a more severe coagulopathy with the FIB-10 less than 12 millimeters, that they could reduce transfusion requirements with fibrinogen. This was non-significant, okay? This was non-significant data. But I think that if powered correctly, 3 units versus 1 unit, that's kind of significant. I think that's with a much larger study, this might have borne out to actually be a significant difference. There is a current trial ongoing right now that honestly sounds pretty similar to the previous study I just showed you. It's another multi-centered randomized double-blind placebo-controlled trial. They are including all patients postpartum hemorrhage needing further management. They will be randomizing 3 grams of fibrinogen concentrate to placebo. Primary outcome similar, just ongoing transfusion and ongoing bleeding, hemoglobin drop. And they're enrolling, and it's actually supposed to be done this month. This study sounds to me like pretty early postpartum hemorrhage as their inclusion criteria. So, I mean, we'll wait for the study to be completed and for the results to be reported, but it sounds like it might be sort of similar to the previous study I showed you of early treatment for a postpartum hemorrhage, and there may be no difference, but we'll wait to see the data. So to conclude, pregnancy is a hyperfibrinogenemic state, And postpartum hemorrhage, at least severe postpartum hemorrhage, seems to be a dysfibrinogenemic state. The therapeutic target level for postpartum hemorrhage is still ill-defined. Definitely lower levels are associated with either severe postpartum hemorrhage or conversion of postpartum hemorrhage to severe postpartum hemorrhage, so an escalation of the hemorrhage, especially if you're down there at around 200. So fibrinogen concentrate can be replaced with multiple agents. As far as amount of fibrinogen that you can get with the amount of volume that you'll be administering, fibrinogen concentrate and cryo will get you a little bit more bang for your volume, definitely compared to FFP. It doesn't seem that fibrinogen concentrate is useful all that much in preemptive treatment of postpartum hemorrhage. And what I can conclude right now from the randomized trials, they're lacking power to show a benefit of fibrinogen concentrate for treatment of early postpartum hemorrhage. There is no trial that really focuses on treatment of severe postpartum hemorrhage, although maybe you can get that from subgroup analysis data. So at this time, I really can't recommend fibrinogen concentrate prophylactically for postpartum hemorrhage or even for early postpartum hemorrhage, but maybe when the data comes out, it'll be useful for severe postpartum hemorrhage or when you have real good evidence of an ongoing coagulopathy from, say, one of the DIC sort of postpartum hemorrhages like abruption or AFE or very, very severe hemorrhage. Thank you for your attention.